accident.
Hello and welcome to Out of the Fog. I'm Lynn Hammond. Tonight, my guest is Dr. Pat Parfrey, and he's here to discuss the Health Accord. Join us after these messages.
You're watching Rogers TV St. John's.
You got this.
Thank you.
You can't outrun your destiny.
My name is Shang-Chi.
You're watching Rogers TV St. John's.
And we're back with Dr. Pat Parfrey. Thanks so much for being with us today. I know you don't mind if I call you Pat.
Absolutely.
And so,
Absolutely, I don't mind.
And so, many people would know you, particularly in St. John's, for a number of reasons. Of course, a distinguished doctor, your role with, the Rugby Association. But today you're here to talk about the Health Accord because you decided to undertake a pretty enormous task along with Sister Elizabeth Davis. So we really appreciate you being here today.
Thanks very much. No, I didn't decide. The Premier asked myself and Sister Elizabeth whether we'd consider doing it, and we said we would.
And you accepted?
Yes.
Yes, well, that was a big decision to accept, for sure.
Yeah.
But, maybe people, we could share with people a little bit at home, your background and experience. You came to Canada in the 80s and originally went to Montreal, is that right?
Correct, yeah.
And so how did you end up here?
So I was doing a fellowship in the McGill University in kidney disease. Mm-hmm. And my wife was doing a fellowship in neurology in the Montreal Neurological Institute. Mm-hmm. And at the start of 1984, I got a call from a Dr. Henry Galt, who worked here, asking me whether I'd come to Newfoundland, and I said no. I wanted to work in a big centre. I was a research person, and that I was an academic, etc. And he rang me back a month later, and to get him off my scent, so to speak, I said I would come down and visit St. John's, and I can still remember going up the hill there by Brother Rice High School and saying, this just looks exactly like my own town. A hill, a Christian Brothers School on a hill. And I said to myself, gee, I think I'd like to work here.
Oh, wow. So it was that little bit of kind of similarity to Ireland that...
It was very much like my own hometown, and the people I met, there was a lot of Irish people and people with that cultural background, so to speak. So I was attracted by that, I think, at the beginning, and then got the sense that it would be a good place to bring my children up. And at that time, I had 2 children. And my wife was very surprised when I said yes.
Yeah. And so, taking on a healthcare role here in Newfoundland and Labrador, you knew it was going to be different than those larger centres. But, within the last 30 years, there have been significant changes in healthcare delivery. What are some of the things that have really stood out to you?
Well, when you're working in the system, it kind of occurs gradually, I think. We're getting more and more doctors and more providers across the spectrum. And there are more and more choices to be made, and there are more and more diseases that we know something about. So it's become substantially more complex, and I think that the availability of the internet has made knowledge easier to accrue, both for people who use the knowledge as doctors, but also for the public who want to know what's going on with themselves. And then within my own specialty, which was kidney disease, the team approach to care developed substantially, such that when I stopped doing clinical work, but The team approach was very strong in the dialysis unit, for instance. There was, you had doctors and nurses and allied health professionals, etc., and people who were technicians for dialysis, all working together. And the most important person wasn't the doctor. The most important person was the nurse in charge of the unit.
And so, even if we just take a step back to the internet, I would think that's a bit of a double-edged sword for the healthcare system. People potentially self-diagnosing or, from the patient perspective. Is that correct?
I think it is. It is correct. People look up stuff and they see the differential diagnosis, as they call it, like what the potential causes of their symptoms are, and then they go to the one that's the worst, and they think they have the worst. And then they want to be reassured they don't have the worst, and then they end up getting tests that they don't actually need. So I think that is definitely a side effect of the internet.
And testing is a significant cost for the healthcare system. With all of these advances in specialties, we see now that family doctors are not necessarily prescribing or requesting tests. It has to go to specialists. So that's something that's evolved over the years as well.
Well, it's evolved as a result of the complexity of some of the tests. So the reality is that family doctors are the people who order, they're the gatekeepers for the system. So they order tests to see what's going on with their patients' problems, both blood tests and imaging tests. And then with complex tests, the indications are more specific and more restricted. And for instance, there is for MRIs, which is the fantastic test, but there's a limited access to them. Family doctors don't order those tests at the present moment, and so then you have to go to specialists to get that particular test. So it's there's a kind of a balancing required, because if you take CT scans, we have 13 CT scanners in this province, which is a large amount for the population. And we probably do quite a lot of unnecessary CT scans. So you've got to balance this issue of what's necessary and what needs to be done as fast as possible to try and get the optimal way of using the test.
And so when the Premier came to you and to Sister Elizabeth and said, we need to better understand the healthcare system, what all of our stakeholders and our citizens are seeing, experiencing, and go forward with a long-term plan for delivering healthcare better. As I said, a monumental task, but you're also engaging members of the public who might not necessarily have that full perspective and understanding of the inner workings of healthcare. So, when you first started with the process, I know there's, an organization of other people who are also working on it, but where was the start? Like, how do you decide, or, collectively as a group, how did you decide what path you were going to take?
So I think that the request to deal with this task force derived from work that had been done in a group that I'm involved with called Quality of Care NL, where we had assessed the quality and performance of the health system. And so that was probably the reason that I was asked to be involved in it. And Sister Elizabeth was a well-known administrator and a very strong personality, who was also asked, probably to put a lid on my aggressiveness, but anyway. So that was the original reason, and we were given a very broad mandate, which was give us a plan about how we can improve health in this province over the next 10 years. And that was it. We weren't given any other directions. You have to do this, you have to do that. You can select your own people and come back to us, and we think that a year's horizon would be reasonable. So at that time, we decided that we'd go two routes. We'd have a route that was related to public engagement, that we would communicate with the public regularly about the directions we were going to, and then the actions that would arise because of those directions. And that we'd go to the stakeholders in the province with the same thing and communicate with the political parties and the government, so that they were aware of what we were trying to do, that the public had full engagement about what was going to happen. And then at the same time, we had these strategy committees, and we ended up with 10 of them actually, in which we we populated with 11 people in each committee, selected really based on their expertise or whether they represented the community or whether they represented a region. But there was a balance of gender and expertise and region on those committees. And their job was to take the evidence that we had pulled together about the strategy that we're approaching and come up with the action plans to improve those areas. And it's amazing the match between what the public were telling us and what the strategy committees were telling us.
And so you did get, throughout the past year, you have had significant public participation. Is it about what you expected, or were you surprised?
Oh, it's far greater than what we expected.
Oh.
We as a group got worse as time went on. We wanted to do more engagement, if you know what I mean, or better, whichever way you look at it. Yeah. So we felt that we wanted to engage with each stage of the process with the public. So we had these town halls, and we had, each time we engaged, we had a minimum of 5 town halls, and that were done by Zoom or webinar. And then we had at the same time we had engagement with multiple stakeholders, particularly the stakeholders on the task force, who were the unions, the regional health authority CEOs, the Medina, the medical school, the CEO of Nelchi, the finance minister of Nunatsiavut, people who had a vested interest in what was happening in the health system, and we communicated them at regular intervals, and then we created various ways of communicating with interest groups and community organisations and groups that were, we did a huge engagement with community organisations. So we've probably, I would think that we have spoken directly to 10,000 people. Oh, wow. And hundreds of organisations that they themselves have connections to more people.
And so, I know there was initial research as well, with regards to the status of health, recognizing we're an older population, with certain diseases and conditions around, obesity, heart disease, diabetes, and some of those things. Were they surprising to hear, some of that foundational research?
I think we were driven particularly by the fact that there is a compelling case for change. We can't go on as we are going.
And are people open to that change? Like, when in consultations, are people kind of talking about the problems, or are people shifting now to solutions? Because it's a lot easier to say what you don't like, right? But accepting change can sometimes be a challenge.
Change is very difficult, and there's little doubt that we've gotten pushback on some things in terms of the way that we thought they should go. We've changed our mind about certain other things, and then there are certain other things that we think need to happen. We feel that people won't like that change to some extent, but at the other level we need to persevere in explaining why we think this is necessary, because what we've currently got is unsustainable.
And sometimes people think that public consultation is about reaching consensus, and that's just simply not possible. You can't please everyone all of the time. In a situation like healthcare reform, it really has to be evidence-based.
Well, I think first of all we chose, it's not public consultation we chose to do. We chose to do public engagement.
Public engagement.
No, I'm not correcting you with. Right. I'm only going to make the point that we felt that we had to go out into the public without telling them what to do. That we had to have a framework for discussion, and that framework was going to be discussed and would be changed if there was good reasons for saying that's not the right framework. Okay. So that happened on lots of occasions.
Okay.
So I'll give you some examples. So we started with 6 strategy committees, one around social determinants of health, ageing, community care, hospital services, quality care, and digital technology. And at the end of our first engagement process, we were told in no uncertain terms through the engagement process, you haven't got it all right. What about governance? What about health literacy? What about provider readiness? And by that they meant the distribution and mix of providers and their education. And what about financial decisions around what you're planning to do? So we integrated those 4 pieces into what we were trying to do. So that's how we went from 6 committees to 10 committees. So that was a major change. And that was driven by the public engagement process. And then the other ones are kind of more specific. For instance, Carbonear Hospital felt that they were going to get disadvantaged by what we were thinking of doing. And from our engagement, they thought that surgery wouldn't be recommended in Carbonear Hospital, which was not the case, to be honest, because the engagement process that we had recommended implied that was the situation, but this was a framework, and that's not the so that engagement process allowed the people within the Carbonear area to understand what we were trying to do.
And so I mean, and I guess that's something that you probably had to address all along was perhaps some misperceptions about the process, worries about the delivery of services in rural areas, because that's some of the commentary that you hear. People still want to make sure that, they can receive, quality health care wherever they live.
It's absolutely true. So we had an engagement process with a council of mayors, and one of the mayors said to us, we don't want to lose anything we have, and we want more.
Yeah.
Right, so that's perfectly reasonable. That's a reasonable approach. So we got to then say, well, what's sustainable? Are all these services sustainable based on the catchment area you've got, the size of your population? And how do we get you better care? And we believe that the best bang for the buck at the present moment is these community teams, where you've got a team of, and this is for care in the community now, you could think of it as primary care, family doctors. When we felt that if you had a team of family doctors, nurse practitioners, nurses, allied health professionals, that includes physios and OTs and social workers and mental health workers, all working as a team, not necessarily living in the same, working out of the same place, connected digitally, and provided an access coming from the population, digitally if necessary, and in person as was feasible, that model of care was the glue that would hold the system together. Now that's a different model of care to what people are used to.
Yes.
So that change is going to take a bit of time to understand. The provincial government have rolled out such a kind of a model like that, what they're calling collaborative teams. And we think that having doctors work to their scope of practice and nurses working to their scope of practice and pharmacists their scope of practice, that there'll be more providers available and that they'll be working in the areas that they're expert at.
So since you brought up scope of practice, we also hear commentary, from different organizations about who gets to deliver different scopes of practice. From province to province, sometimes there's variations between what a nurse practitioner can provide versus a family doctor versus a nurse, some of those things. So is scope of practice something that's been discussed? I mean, I recognize that that's kind of a bigger piece that involves unions and stuff, but I mean everybody's participating in this conversation. So is that something that's started to open up to be discussed? Oh
yes, absolutely. I mean the reality, the scope of practice is really determined by the regulatory bodies. So and the training that people get in their particular job that they're in, the particular place they're trained in, determines what they're able to do. To our way of thinking, a doctor is probably able to look after 1,250 people. And in the fee-for-service model, it provides a lot of different things that might not necessarily be provided by a doctor. If you end up with if you have a team that integrates family doctors, nurse practitioner, and nurses, then the catchment population doubles to about 2,500. And they're able, if they work at their full scope of practice, they're going to be able to provide a more extended coverage for the person and for the family there. And then if they're married to allied health professionals, you've got an even more extended type of practice. So it is, to our way of thinking, it should provide better quality care to more people.
And COVID really shook up healthcare service delivery. The fact that people had to get used to doing, some telephone meetings with their doctors or some virtual care. We all recognize that obviously, it's extended wait lists and delays, but specifically around the delivery of care virtually. Is that something that people are now starting to accept? I mean, I remember being in Grey River maybe 20 years ago, and they were early starting, to talk about virtual care. Did COVID kind of push that to the forefront?
There's little doubt that COVID pushed it to the forefront, because the day that COVID started, the number of visits to a family doctor dropped by 60%.
Right. Yeah.
Right. So there's no, and then the only way you could deliver care was through virtual care. Mm-hmm. Now it turns out that was delivered mostly by telephone, which I don't fully support, to be honest. But the drop in the number of visits to a doctor, to a family doctor, has persisted for the last 17 or 18 months. Mm-hmm. And the number of, the combination of virtual calls and visits hasn't dropped, it's actually gone up.
Okay.
So the doctors have been in connection with their patients, the family doctors have been in connection with their patients in the same way as they were before COVID. And I think that some people found that the virtual calls for certain things were fine. They had no problem with certain things, getting their prescriptions refilled or something.
I found it better.
Yeah, it's
for me personally, and of course, depending on circumstances, but for refilling of prescriptions, for those kind of routine blood work, some of those things, it seemed to work well. I might not have been so open to it before.
Correct.
Yeah.
I think that's what you just said is probably the general opinion. But then at the other side, you've got people who have a problem.
Yes.
And they need to be seen.
Yes.
So what does that mean virtually? I mean, to me, it means you need to look at them on the camera. Mm-hmm. So the capacity to use virtual technology that includes you imaging the person is important. And then there are situations where you have to see where you have to examine the person. Mm-hmm. So getting that decision right is part of what virtual care is about. And then in the hospital side, the change was very different. There was a drop in visits that kind of persisted a bit. Virtual calls went up, but didn't stay up. Mm-hmm. And the total number of visits that a specialist has gone down, actually, during COVID. So they used virtual technology in a very different way. But our vision is that we have to jump in to making this virtual care work. Our province is too big, with too few people in it, and so dispersed, and the need for specialty services is so evident, and they can't be in every community. So from our perspective, virtual care is a necessity, and getting that properly organised so that rotas are done and if patients feel that they're looked after properly by that virtual care doctor, and specialists go on virtual care in a rota to people who are isolated geographically, all that, it would be a very good thing. And even today we heard from physiotherapy who said that they are now able to do good physiotherapy virtually. Imagine that, right? That
amazing.
A physio who's meant to put his hands on you can do good physio virtually, so that somebody who's on the coast of Labrador can get proper physiotherapy treatment. So there's an undoubtedly capacity for virtual care helping us.
So, when and I'll call it the team, because obviously, it has, with all of the different committees and, when do you present findings to government? Like, what's the next kind of steps?
So we're writing the accord right now. Sister Elizabeth is writing the first draft this second. And this is why she's not here for this interview. And we anticipate that between writing it and getting amendments and input from the 130 members of the task force into the content of that accord, that'll take another bit of time. We've made a conscious decision to divide the accord into two. One is the accord itself, in which we would like the stakeholders on the task force to sign off on the content, which would include 12 major tenets for agreement about how we would improve health in this province. And then about a month later, we'll come out with a specific implementation plan that would be a blueprint for the delivery system, because the task force ain't going to deliver.
No.
So the blueprint would allow the health and social systems to communicate with the publics in those areas and work out how best they can roll out the health accord to have better health.
Our sincere thanks to you and to everyone involved with the Health Accord.
Thank you very much.
And we'll be right back after these messages.
It all started when I racked up some serious debt. Interest payments were going up, creditors were calling. Janes and Noseworthy came up with a plan. Knowing that the phone was going to stop ringing and that I was not in this alone was a huge relief. Bankruptcy or a consumer proposal or whatever help you get is not the end. It's just the beginning. A chance to start again with knowledge and support and people in your corner. Are you ready? Get out of debt. It's okay.
Learn more about Leah's story at janesnoseworthy.ca.
Yo. Yep. Okay, I'll be there.
Thanks so much to Dr. Pat Parfrey for being with us here today to discuss the Health Accord. You can find out more at healthaccord.ca. Join us next time on Out of the Fog.
If you have a comment about this program, we'd love to hear it. Email or call us, or send us your feedback through social media.
This is Rogers TV.
What a fantastic matchup.
Oliveira, longest active win streak in the UFC.
Dustin Poirier is beating world champions. He's here to get his hand raised.
I'm gonna win by any means necessary.
Amanda Nunes!
The greatest of all time.
There's no one even close to her. Who is going to rise to challenge Amanda Nunes? Juliana Pena!
I am here, and I am ready to fight.
2 championship fights.
No mercy.
My Uncle Cheney was